Hello and welcome. My name is Donna Cryer. I am the CEO and founder of the Global Liver Institute, and I am so excited to be able to bring you this expert panel on NASH and diabetes for International NASH Day 2021. NASH is non-alcoholic steatohepatitis. It is a very serious disease that needs to be addressed with urgency. It affects more than 115 million people around the world, and its prevalence is rising with rates of obesity, diabetes, high cholesterol, and everything else that has been rising and exacerbated during this time of COVID, with us locked inside, many of us specializing in sourdough bread bakery and other wonderful hobbies, but bad habits for our overall liver health and our metabolic health. And so as we approach this great grand reopening, hopefully everyone listening is vaccinated or will soon be. We want to make sure that you have the expert advice on how to do that well and address NASH if it hasn't been addressed, or how you can work with your physicians, or if your physician work with your patients to get the care necessary as we all come back together. And so I wanted to just introduce this year's theme for International NASH Day. It's NASH around the world. Throughout this day, we'll be giving you insights, visual, verbal, social, and otherwise, into how NASH is experienced in several countries around the world. If you want to promote these and share some of your experiences with NASH around the world, please use the hashtag NASH Day. We are so honored this year, our 4th year of doing International NASH Day, to be endorsed by so many medical societies. Really, we are honored as a patient advocacy organization to be endorsed and in such partnership and have the support of so many medical societies around the world. And we want to give a special thanks to FAASLD, the American Association for the Study of Liver Disease, and to EASL, the home of hepatology, the European Association for the Study of the Liver. But here you have a host of our new partners, so many of them for the first time this year supporting International NASH Day, and we thank them. And so, without further ado, I want to introduce our expert panel and start this fantastic discussion. We have Dr. Ken Cusi, who has been such a pioneer in uniting hepatology and endocrinology. He is a professor of medicine and chief of the division of endocrinology, diabetes, and metabolism at the University of Florida. We have with us Dr. Stephen Harrison, who I think is one of the, if not the most published hepatologist on this subject. So we're so excited to have him today. Dr. Harrison is a visiting professor of hepatology at Radcliffe Department of Medicine, University of Oxford, but we would of course be remiss in not acknowledging his Texas roots and his home there in San Antonio. So, and then we have with us as well Dr. Pinar Topsever, who is Vice Chair of the Primary Care Diabetes Europe. So welcome all of you today.
Thanks for having us.
Yes, thank you. Absolutely.
Fantastic. So I start with you, Dr. Topsever. What has changed in NASH and diabetes, our understanding of the connections between the two of them, and care for patients who might have both in the past 12 months?
Donna, first of all, thanks for having me, and also on behalf of Primary Care Diabetes Europe, we're very happy to contribute. Maybe I should start with what hasn't changed. First of all, the epidemiology, as you were very correctly referring to, has not changed. And Europe having the highest prevalence is in NASH, according to a recent systematic review of 68%, is of course one of the regions where especially primary care physicians should be very alert about this condition. But what has changed, as we all know, the topic that is ruling the world is the COVID-19 pandemic, and this whole cardiometabolic disease cluster where NASH is a part and a result of, it goes under chronic diseases, and these sort of diseases have been, well, I don't want to say neglected, but there were a lot of missed opportunities for chronic care. And also for follow-up and prevention, secondary prevention screening, and we know that diabetes and NASH coexist to a great extent. So the concept of multimorbidity, or even say comorbidity, with one of them being the index disease, the causal factor, is present in this relationship, and also NASH being quite prevalent in primary care, around 17%. So that's quite high for a primary care population. That is something GPs need to be alert of, and also be in charge of, also during a pandemic, of following up these patients with these chronic conditions. And although I have unfortunately not come across any evidence about what changed in the outcomes of the people with NASH, there is a recent UK study which there says, and that's really very alarming, that during last year in the UK, the mortality for people with type 2 diabetes has doubled.
Wow.
And there have been approximately a missed 60,000 new type 2 diagnoses due to this hegemony of the pandemic and this communicable diseases and everything. All the resources shifted to secondary care, and primary care was sort of deactivated, and that was not at all good for all the chronic disease patients. So that's the biggest change that I can tell you about.
Huge, and that should be a big headline. Stephen, one of the things that we were worried about in the past 12 months was that NASH research would come to a complete halt, but that hasn't been the case. Can you talk about that?
Absolutely, Donna. So I just foot stomp what Pinar said. I mean, there has been just, I guess, a better awareness of the link between diabetes and chronic liver disease relative to COVID-19. Lots and lots of publications out now linking worse outcomes in the setting of COVID with underlying diabetes and liver disease. So that has actually heightened a bit of an awareness, at least in the US, as that pertains to NASH clinical trials. While there was a slowdown, we were able to continue to enroll studies. In fact, interestingly, some of the patients we saw came to us specifically knowing they had diabetes, knowing they had underlying liver disease, reading the press clippings about their increased risk for COVID bad outcomes if they were to be infected with COVID. They stepped forward and said, please help me treat my liver disease, because if I do get infected with COVID, I want to have a shot at a better outcome. And so as a result of that, while there was, again, a decrease in clinical trial enrollment, we were able to continue to push through that situation. And now coming out of that a little bit on the back end, we're really primed to accelerate clinical trial development. And I would say, as something that has changed in the past 12 months, more and more therapies are coming forward showing a positive impact on non-alcoholic steatohepatitis and diabetes. So not just improving the underlying liver disease, but also improving glycemic control, and doing that in such a way that doesn't increase adverse events and comorbidities for these patients. And hopefully there's an opportunity to speak a little bit about what some of those therapies that are forthcoming look like. It doesn't mean we don't have things that you can use today, and Ken is a pioneer in using pioglitazone and other therapies to manage diabetes in the setting of fatty liver disease. But there has been a world of new data that has come forward relative to diabetes and fatty liver disease in the past 12 months.
And Ken's name is on most of it, so we'll allow him to address it. But my main question is: should every patient with diabetes be asking to be screened for fatty liver disease?
Well, again, adding to what Pinar and Steve said, I mean, these are great times, challenging times. COVID has added a lot of anxiety and uncertainty, and definitely has led to more inactivity and some weight gain that I see in clinic. But on the positive side, as Steve said, I mean, there is an increased awareness among patients. And there's a building evidence in the field that fatty liver, and more importantly, fibrosis is prominent. So Steve published key work in this regard, and we were able to contribute with a study that we basically recruited during the COVID time in about almost 600 patients, showing that 2 out of 3 people with diabetes have fatty liver, and up to 1 in 6 have moderate clinically relevant fibrosis. So we've been continued looking into this. I think the greatest advance to me is a very simple one, is that primary care doctors, like Dr. Topsever said, have realized that this is something we have to look at. And my goal would be that the ADA, which has now asked to screen patients if they have elevated liver enzymes or fatty liver, I think my hope is that it will do it systematically, and all people with diabetes get some sort of test, and we can discuss which will be the best algorithm. Because there are things you can do now, as Steve said. And by the way, we published that first paper with Steve, so it's a 50% credit on pioglitazone, and it costs $5 a month. So there are things now you can do. And in November with Steve, we also published a study with semaglutide, a GLP-1 receptor agonist. So there are things you can do in addition to lifestyle, which is key to treat people with diabetes and NASH, and maybe less for people without diabetes, although vitamin E is an option and pioglitazone can be used. But there are things you can do now to reverse this. So it's very important we make the diagnosis now, and don't just wait for future drugs, which there are many promising drugs in the pipeline.
Donna,
Go ahead, Stephen.
Yeah, so just to speak a little bit more about diabetes and really speaking to patients and at the primary care level, what we've seen is over the past 3 decades actually, from the 80s now, late 80s into 2021, is a significant rise in the prevalence of fatty liver disease. And that link to diabetes is so profound. And if I could just speak to our recent publication, I think that reinforces what we've known all along. So this is a study where we looked at patients that were presenting for routine colon cancer screening. So they didn't come in with bleeding, or they weren't having a colonoscopy for any other reason except for their underlying colon health. And so they were generally healthy individuals. The median age was around 55, 56 years of age. And we asked them if they wanted to know their liver health. They were here for their colon health. Do you want to know your liver health? We excluded patients that drank alcohol to a certain degree, that in an alcoholic liver category, medications that cause fatty liver, any known history of liver disease or fatty liver. And in that setting, patients then signed consent. We did blood work on them, We got a full detailed demographic history, and then we sent them for the gold standard evaluation for fatty liver, an MRI proton density fat fraction. We did additional MR work, cutting edge work with multi-parametric MRI, MR elastography, as well as FibroScan. And ultimately, if patients had any risk factors along the way, we offered them a liver biopsy. Now, we did a very similar study published in Gastroenterology back in 2011. And so there's some interesting comparisons that can be made from data generated in the early 2000s and published in 2011 compared to data generated in the late 2010s and published just recently in 2021. And that is the prevalence of fatty liver has remained relatively the same by MRI-PDFF in this population of patients. The prevalence of NAFLD is 38%, 38%. And the median age, again, 56 years of age. More importantly, when you stick a needle in their liver and you look at the prevalence of NASH, it's 14%. And when you go back to the first publication 10 years ago, the prevalence of NASH was 12%. Again, similar type thing, prospectively evaluated with liver biopsy using a 14 gauge needle, which is a very large needle. We get a great sample of liver tissue in a double blind fashion by 2 liver pathologists in Europe. And so I think the data is accurate. What we've seen is a rise in the prevalence of NASH, but more importantly, a rise in the severity of NASH, as Kenneth alluded to. We went from around a 2.9% back in the first publication having F2 or F3 disease to now 5.9%, a 40% increase in more advanced liver disease over that decade of time or so. And then when we focus on diabetes, 70% had fatty liver, 35% had NASH. And so that's in line with what's been published previously. It's in line with what's been presented in a systematic review and meta-analysis. And it underscores the real importance of diabetes because additional work by Rohit Lumba and others have shown that there's a subset of people that are rapid progressors. Their disease in fatty liver progresses very rapidly. And diabetes is an independent predictor of having a possibility of being a rapid progressor. So that's also news that's come out in the past year, and I think it's worth highlighting.
I think that advance of news in this past 12 months of the growth of this evidence, of more research, of more studies, and more precision about understanding the prevalence and the degree of severity of NASH in so many underlying populations. People with diabetes, people who are just walking in who think they're just getting their colon cancer tested, really speaks to how underreported, underdiagnosed, underaddressed fatty liver disease and NASH have been all along. And so to have a day like today on International NASH Day to really focus and shift that, so people are getting that screening. So you can't treat what you're not looking for. So to look for it, and this evidence that when you look for it, you're unfortunately finding so much disease is really important for people to know. Pinar, you wanted to jump in?
Yeah, I just wanted to echo and second what my respected colleagues and you, dear Donna, were saying, that early intervention and a proactive clinical approach and avoiding clinical inertia in screening, as Kenneth was saying, as well as in the treatment, as Kenneth and Stephen were both highlighting, is very, very important. And because all this, deleterious exposure to unhealthy lifestyle is community dwelling worldwide, unfortunately, even more so now in the pandemic, as all of you were mentioning. It is very important to empower primary care and to raise an awareness among family physicians and GPs to have the guidelines, of course, and to also open access to care for the general population over primary care for this condition, to manage this condition better. And once the fibrosis has started, although I'm not basic scientist. I'm a, GP with a very epidemiological and pragmatic clinical approach. I know from diabetes that diabetes is a model of accelerated vascular aging. And once this stiffening has started, the point where the patient is below good and evil can come very quickly. And it's, I guess, I dare say, it's the same about fibrosis. So we start with the fat deposits, which go up to 5% in the liver tissue. And if you think 5%, oh, it's just 5 in 100. No, I mean, you can go there quite quickly, and then the risk for fibrosis starts. So we have to be really proactive, and we aren't. So that's what I wanted to say.
Let's be specific in that proactivity. So let's assume that every physician who's listening says, okay, yes, I'm going to do it. What's it? What does screening mean? And so, Stephen, what is screening for fatty liver disease mean? Like, which tests, in which order, in which conversations? I know it's a big debate, but when I talk to GPs or family medicine, internal medicine folks, they're like, we have a lot of things to do in a short amount of time. Okay, we'll screen. Is it easy? Is it simple? What does it look like? And Ken, then I'm going to go to you for what does it mean to manage a patient who has diabetes and NASH? So, Stephen, how do you look for it? How do you screen? What does it mean?
Absolutely. So I think as a hepatologist, we try to make it complicated, and it doesn't have to be complicated. In fact, it needs to be very simple. In the military, we followed the keep it simple, stupid rule, the KISS principle. And I think another military acronym is BLUF, bottom line up front. So the bottom line up front for primary care providers is you just need to be aware that your patient is potentially at risk for fatty liver. And you know what? You're not going to miss a lot of it. If you think that 38% of the adult population has fatty liver, bring that down to a third. You have a 1 in 3 shot just shooting in the dark that you're going to find a fatty liver patient. So understanding that up front, what increases the odds that you're going to have a fatty liver patient sitting in front of you across the table are risk factors such as all metabolic syndrome components: diabetes, obesity, hypertension, hyperlipidemia. And really what we've learned in clinical trials is if you have 2 or more of those risk factors, that really heightens your probability of having not only fatty liver, but the fatty hepatitis, the non-alcoholic steatohepatitis with fibrosis. And we know fibrosis portends a worse prognosis. So we're really trying to get after that at-risk NASH population. So first of all, look for metabolic risk factors. Second of all, ask a family history question. Do you have anybody in your family history with known liver disease? And even if they say yes, but so-and-so drank, it doesn't matter. They're in that category. That's a positive family history that needs to be looked more closely into. Second of all, very pragmatic, very simple. If you have a set of liver enzymes, look at the AST, look at the ALT. This is an ALT predominant disease. It should reign over AST in a 2-to-1 ratio in the setting of mild fatty liver. As the AST rises to the level of ALT, the risk for advanced liver disease, that at-risk NASH population, rises by an odds ratio of 9. And so it doesn't work if the liver enzymes are stone cold normal in the teens. But if you have abnormal liver enzymes, really defined by an ALT, AST above 40, and they're the same number, bells should be going off in your head that there's a problem. This patient is likely to have at-risk NASH. So that's something very simple. Look for metabolic risk factors. If you have liver enzymes, look at the ratio of what AST is to ALT. If you don't have liver enzymes, or if they're normal, it doesn't mean that you're getting off the hook here. So there are other things that you can very simply do. If you have a FibroScan at hand, do a FibroScan. And there, if the CAP, the CAP score is above 280, 300, they have fatty liver. Then look at the KPA, the kilopascal score. If that's less than 6, they have fat, but they don't have any fibrosis. And you can tell the patient, good news, a great joy for today, in whatever city you're in. You don't have risk for NASH today, but we still need to address your fatty liver because we know fatty liver, the presence of fatty liver increases the risk of diabetes development by at least twofold. So you're not off the hook, but we can focus more on managing your comorbidities rather than your liver disease per se. If you don't have a FibroScan, there's other blood tests that you can do. What I would tell you about these is that they're best utilized for their negative predictive value, meaning if you have a negative test, hang your hat that that patient has a low risk for developing NASH with a lot of fibrosis. A couple simple tools that you can use. There's online calculators. You can calculate what's called the FIB-4 test, which looks at AST, ALT, again, those two liver enzymes, platelet count, and age. And then you can also calculate the NAFLD fibrosis score, online calculator for that as well. There are some proprietary blood tests you can send off as well. But if you wanted something really, really simple, I said at the very beginning, we'll keep it simple, stupid. I think for me, demographics, metabolic risk factors, AST, ALT ratio, look for that ratio of close to 1. If that AST is close to ALT, bell should be going off. If you have a FibroScan, use it. And then if you don't, maybe FIB-4 NAFLD fibrosis score, look for the negative predictive value there. If you're below the cutoff that we've published, then you're good to go. If you're in the intermediate or high risk category, please refer those people on. Now, I get asked this question all the time. Why should I be looking for fatty liver if there's nothing I can do for it? Well, as Ken will tell you, there are lots of things that you can do for it. Not just educating the patient about healthy lifestyle choices, but there are some medications that have been on the market for a long, long time that cost pennies that you could try your patient on as well. Ken can speak to that. But even beyond that, clinical trials, we are so far along now in our drug development platforms for NASH that we are on the cutting edge of having FDA-approved treatment for this disease. And beyond that, the drugs that are in the pipeline are really beginning to move the needle in NASH, fibrosis, defatting the liver, and then managing glycemic control and atherogenic lipids, because we know these patients are increased risk of cardiovascular disease. So we want to give something that not only helps their liver, but also helps those atherogenic risk factors as well.
You know, Stephen, I want to say two things before we pass this to Ken. I've actually used those. I wanted to know my risk for NASH. You know, as somebody with a history of liver disease and somebody who cares about my liver health and cardiovascular health and all of that. And so I did, you know, pull my lab results from my patient portal and use those calculators to calculate my, you know, my risk for NASH. You know, thankfully I'm you know, low risk, but it's good to know, and it's something that patients can do for themselves, and maybe start the conversation with their physicians, coming in with, you know, not just random sort of Google search or things, but with, you know, I use this online calculator, the number I came up with based on my labs and, you know, my history, as I said, and my concurrent conditions, and let's have a conversation, you know, based on that. As you know, we partner with physicians to you know, to get to these diagnoses and to do this, you know, easier. And then also, I just wanted to say, you know, spending time with you and listening to you and your advice to patients, I've actually lost 5.5% of my body fat in the past few months.
Great job.
So thank you. Doing some really simple things. You know, moving from more, you know, protein to from concentrated sugars, and exercising a little bit more, particularly with weight training. And so just to, I don't want to be, you know, giving advice to patients saying, well, you know, lose 5 to 7% of your body weight without, you know, doing it myself. And so I just wanted to say I did, and, you know, it is doable. And so, you know, Ken, what else can people do in partnership with their physicians and their care teams?
Well, both Pinar and Steve covered a lot, so I'm just going to go quick. So some points. Number one, why diagnose fatty liver? If you have type 2 diabetes, we're talking, and fatty liver, the diabetes is more difficult to control. Likely you have more insulin resistance, more dyslipidemia, And turning this around is very important. If you have pre-diabetes and fatty liver, your chance of developing diabetes doubles or triples, many studies. So for us as diabetologists, it's important because we have 6 to 8 diabetes medications, but only a few help for fatty liver disease. So it will make the selection of our diabetes medications based on the pathophysiology of the disease. So that's very, very important. The other aspect that Steve also many times mentions is perhaps endocrinologists and primary care, if they don't have time to calculate the FIB4, at least they should think of lowering your threshold for awareness or the risk of fatty liver, because in the general population, as Steve said, it's about 1/3, but Steve and everybody of us know that if you have diabetes, it's 2 out of 3 have a fatty liver. And if you add that a BMI of 35 or higher, it might be 4 out of 5 patients have a fatty liver. So you probably in diabetes or pre-diabetes have to work on the assumption that they do have a fatty liver. Now, what to do?
In Europe, the coexistence was 68%, according to the latest figures. Terribly high.
About 2 out of 3 for a simple thing. So one practical thing, if you don't have a FibroScan or imaging at hand, if the AST or ALT are above 30, just remember one easy number. It's not. There are some issues about it, but think of anything above 30 should make you begin thinking about fatty liver, particularly in women. Now, many don't have a FibroScan, but your liver doctor does. So the mission we have as endocrinologists, primary care, is to try to send them those at the highest risk. So with the FIB4, you can easily rule out at least half of the patients not being in a high-risk group. And 1 out of 10 will be clearly identified of having a high risk with not spending a penny. Now, once you identify this, again, structured programs for weight loss are the best. And you need to think about that if it's available. Bariatric surgery is underutilized. And if you have diabetes, Steve and I have shown that pioglitazone, which is an inexpensive drug, works. We start with 15 milligrams. And again, avoid it if you have heart failure or if you have osteoporosis. But most patients will be able to take it. The debate about bladder cancer has diminished significantly. Most studies are negative. Of course, don't give it to somebody with a history of bladder cancer. There's always controversy. Start 15 milligrams. Nothing, no significant weight gain will happen. Patients will do well. You can increase it on the next visit. Now, semaglutide has shown on a daily injection, which is a formulation that's not available. But semaglutide has had several studies that have been published in the last few weeks in obesity, helping, although it's not FDA approved yet, but will. And in diabetes to be effective, liraglutide is also shown. So there are options to promote weight loss. And then there's a big class that diabetologists are using, SGLT2 inhibitors, also are promising to treat diabetes and fatty liver. So there are things to do. Hepatologists use a lot vitamin E that is shown in the PIVEN study in people without diabetes to work. So there are things you can do now. And if you don't know, your hepatologist will know. And again, if you're close to a university, your hepatologist are doing many clinical trials. So that's another resource that you should keep in mind.
Maybe we should do an endocrinologist, hepatologist matching service. So everybody can make a friend with a hepatologist.
Yes, I like that.
And know when to refer those high risk patients. I think that's something that we
the physician. It should be a trio of the primary care physician plus the endocrinologist plus the hepatologist.
So let's talk about the barriers to having this happen. So it seems like we want to make it as simple as possible, something that can be complex. There are lots of options for what you can do, but it seems like we need to connect with members of a team, a dietitian, a bariatric surgeon, and others potentially that people may not have in-house. If you're at an academic center at one of these new fatty liver disease clinics, maybe you do have everything at hand. But if you don't, we still want people to get care. So let's think through the barriers, because GLI is pretty good at knocking down barriers to things. So let's identify what are the barriers to having people get this optimal care right now, so that we can, work through what we need to do to remove them. What's stopping us from treating, from screening every person with diabetes with NASH and getting them the current treatments we do have on hand?
I'll say endocrinologists just don't think about it. I mean, that's the major barrier. So if we know about it and we educate our patients, that's going to be a big change, because early treatment works. And again, I find a high motivation in patients when you tell them that they have liver disease. I mean, Pinar, what happens in primary care? What have you found?
The thing in primary care is that there's a hegemony of the cardiovascular disease and a little bit now with the metabolic. So this cardiometabolic disease cluster hegemony. And we just recently started thinking, for instance, in terms of type 2 diabetes, I'm talking about kidney health, heart failure, these things which really deteriorate quality of life immensely, but which were neglected for quite a long time. And I think fatty liver should be one of those. So if this would make its way very quickly into the primary care treatment guidelines, that would help, because GPs look at guidelines. Although they do not always comply, but they do look into them, and access to healthcare. So empowering primary care, for instance, to prescribe this drugs. PIO we can, but SGLT2, GLP-1, for instance, in my country, has to be first prescribed by an endocrinologist or at least a specialist for internal medicine before I can keep on refilling the prescription. So access to drugs would be one thing in many European countries, my country being an example. But the most important thing, as Kenneth was saying, is prioritizing this as a public health threat. It's a threat to public health.
That's a great point. That's a great point.
Yeah,
and I want to hear Steve from the liver side. But one thing we have not talked about is cardiovascular disease and liver cancer. So I have to say, primary care doctors need to be aware, and endocrinologists, that having a fatty liver is associated with more cardiovascular disease. And now what I teach my peers is to think about triangle of care that involves the heart, the kidney, and the liver. And this group of drugs, SGLT2s, GLP-1s, and pioglitazone, improve the cardiovascular risk. But Steve, how do you see it, and what's the deal with liver cancer and NASH?
Well, just to your point, the liver cancer and NASH really go hand in hand. If you look at the rise of hepatocellular carcinoma in our country and around the world, it is significant, and it is directly linked to the increasing prevalence of fatty liver, which is directly linked to the increasing prevalence of obesity and diabetes. If you look specifically at what I call the epicenter of fatty liver for the United States, it's kind of south of San Antonio towards the border in McAllen, Texas, with Mexico and the US. There's a couple counties down there, Hidalgo County, Cameron County. Those, if you look at the CDC website, I think it's the CDC website, and you look at the county demographics relative to hepatocellular carcinoma, those are two of the top counties in the United States for prevalence of hepatocellular carcinoma. That's also, parenthetically, where you see the highest rates of diabetes and obesity. And mixed with this blend of a genetic predisposition, right? We know that Hispanic populations are predisposed genetically to a single nucleotide polymorphism called PNPLA3 that in the setting of obesity and diabetes actually drives liver disease progression, not only to NASH with fibrosis, but also liver cancer risk as well. But you're getting back, maybe I could comment also on Donna's question about very pragmatically, what's the issue in identifying these people? And I've thought about this for years. It's multifactorial. There's not a single thing we can hang our hat on. Lack of guidelines, it's not something that's in a lot of our guidelines to screen for fatty liver disease, even amongst diabetics in the FAASLD guidance document last published in 2018. It's not in there either. Now, hopefully with some recent data by Mason Reedon and his group, that's going to change. But
we need to change that, definitely.
Yes.
Yeah, there's enough evidence to change that, really.
I agree. So there's that. There's an educational component, and we often limit education discussions to that of a physician, but it's also a patient. The patient needs to be educated. The primary care docs need to be educated. And then it gets to time. As a primary care provider, trying to do all the HEDIS measures so that you can get reimbursed appropriately. What's the blood pressure? What's the diabetes? What's the lipids? Everything that you have to manage in a 15-minute appointment. And then, let's talk about fatty liver disease is not something that's built into the vernacular or the paradigm of a typical 15-minute appointment. And then if you have a primary care doc that's all over it and they refer a patient to a gastroenterologist, unfortunately, amongst my colleagues, it's not taken seriously. They look for the colonoscopy and the upper endoscopy. No offense to my colleagues, but there's not a lot of attention paid to fatty liver. And it's just eat less, run more. Here's your colonoscopy. Go back to your primary care provider. And then the primary care provider looks at it and says, well, the GI guy didn't get excited about this, so why should I get excited about it? And then the next several referrals don't happen because there wasn't a lot of positive feedback, and that positive feedback loop is critically important. And then finally, there's a lack of FDA-approved treatment for this disease. And while there are therapies that can move the needle in a positive direction, whether it's vitamin E or pioglitazone or SGLT2 or a GLP-1, the fact that it's not approved for the indication of NASH does hold some people back from utilizing it. So I think it's pleiotropic, it's multifactorial, but all of these are these are all areas where we can improve on. And GLI is a pioneer in that. And part of the reason why I'm glad to be a part of this International NASH Day call with Donna and her team, because I think there is that opportunity to move the needle in so many different directions through platforms like GLI.
I wanted to take a point about the fact that our NASH Care Act, first of all, thank you for that compliment. And we honor and always appreciate your partnership.
We all love your work, Donna, you know that.
Thank you. But you all providing the evidence for our advocacy so that we can take strong messages forward that have the facts for them, and as well as the humanity and then the patient voice and perspectives for them. And I want to give a shout out to our champions on the Hill who come from Texas and New York, Republican and Democrat. They're bipartisan. I think one of the things that links them is high percentages of Hispanics in their constituencies, high rates of NASH, and recognizing the impact that this is having on their communities, and wanting to do something about it. And so I really want to thank our NASH champions in Congress and those who are helping us put forward our U.S. NASH action plan, which includes the Veterans Administration, as well, as we try to make this easier and simpler for physicians and patients as well. And I want to put out just a few ideas for you all to see if they stick, if they think that you're workable. If we had, certainly we need to move on the guidelines so that we could have embedded perhaps in EHRs, a system of alerts that activate and sort of automates this testing cascade or the care cascade, or these things that people can do for management, whether it's pioglitazone or weight loss medications, or referral to a dietitian or a structured program or bariatric surgery, if those numbers are appropriate. If we build this into the EHR in a better way, would it make it more likely that and that doctors could, do the right things? So let me just ask that idea first.
Yeah, that definitely there's evidence for that prompting in electronic health records, patient records, does improve quality of care in terms of, administrating the right steps in disease management programs, and also positive performance. In the UK, the famous QOF.
Yes. Of
care.
I agree.
Hello?
I think that we have in our electronic medical records, we're working on building that at a college level. We have it within our group, and it's
reimbursed.
Helpful.
Yeah.
The FIB4, which costs nothing, by the way, for the audience to know. But we need to think about it. And Steve said, doctors are busy. We have very short visits. So I do think that patient education will be critical. So if they have obesity or diabetes, they ask their doctor, may I have a fatty liver? I've had that happen to me as well. And then doctors reacting positively and developing these multidisciplinary teams. With Steve, we have been in an effort all 2020 with a group of primary care in the United States and hepatologists and endocrinologists and members of the Obesity Society, and we came out with a white paper that's in gastroenterology, coming out in any time now, that tries to say if the doctors don't work as a team, we're not going to resolve this.
Absolutely. And Stephen, to your point about receptivity of certain practices, and I looked at my own large, gastroenterology practice where I go because I have IBD in addition to a liver transplant, and they list liver diseases, but they don't list NASH. So they don't even acknowledge that it's there, to your point. And this is a very large, very well-run, multi-state practice actually in gastroenterology, and they don't acknowledge that it's there. But I have noticed that there are a number of research networks like your own and then NASH clinics that are starting up, fatty liver disease clinics. And so, maybe part of this sort of automated process to support a patient's journey is to make sure that they are sent to a place that wants to receive them, that wants to engage in treating NASH patients and curate that referral a little bit.
Yeah, it's interesting when I go and speak to my colleagues about NASH, there is an interest. They understand that disease can progress, that liver cancer can happen, that cirrhosis can be an end point for NASH. I think the hurdles have been a consistent delivery of that message. If you look at any disease, really, it's once there's a dramatic increase in the awareness of disease when drugs become FDA approved. And there's a lot of reasons for that, because now all of a sudden huge marketing dollars are thrown at the disease. You have commercials on TV, Saturday afternoon football games. You see, commercials for Hep C therapy, for erectile dysfunction, for all these things, but there's nothing on NASH yet. And then you have pharmaceutical reps knocking on the door saying, hey, can I drop off some information about fatty liver disease? Have you thought about this in your clinic? And it's interesting when I go around and I show them FibroScan data on their own patients, they always tend to reply with, oh yeah, that's right. I got so busy. I just didn't remember about this. Thanks for reminding me. So it's these consistent reminders and cues. And the problem is you can't just do one thing. You can't just have a symposium at FAASLD or ADA or EASL and expect everybody to change the way they practice medicine. It really has to be hit from multiple different areas. The way I like to think of it is, if you want to have a meeting with GLI today amongst all your team, you can send one email, but you'll have a lot of people that say, I didn't get the email. And then, you could put a sign up in the bathroom.
That's not allowed in our culture. If I send an email. Everybody breathes.
Okay. Well, you've got a lot more power than I do. But the point is, you have to hit this from multiple different angles. There needs to be guideline development for this, not only within FAASLD and EASL, but within the endocrine societies, the primary care societies, family practice societies. There needs to be a bigger push from organizations like your own. Not that you're not doing a great job, but you're developing the bandwidth now to really get after this on a much broader level. There's organizations, as you know, like, I didn't even know this existed, the Healthy Trucker Association, which has thousands of members, and they are a huge at-risk population. Bringing that awareness to that group, providing informational content like what we're doing today. We just have to get after this from multiple different angles. And that's how we're going to slowly turn the tide. And then obviously when we have FDA approved therapy, that's going to take us to the next level. But we can start now by broadening that educational base more so than what we're doing.
The NASH Council is 70 members now, and if all 70 members, all 70 organizations, and we do need to add the Truckers Association. Dr. Anna Mae Deal from Duke has been telling me about that for a while, and I do know what her CBC name, her CB name is, and maybe we'll auction that off for people who really want to know, or in the after show portion. But we have members from the American Society of Nutrition to the American College of Sports Medicine, to the Association of Black Cardiologists and the Preventive Cardiology Nurses Association. Of course, my first call was actually to the Endocrine Society, and they responded, and ACE, and you're absolutely right. It's so important. We can only do so much, but by leveraging the full power of a very broad network who really claims this condition, this spectrum of conditions, as you said, Dr. Topsever, as a public health issue.
And integration of care is actually, that was what Stephen was describing so beautifully, integration of care and building awareness in the whole society. And that's why your work is so crucial and so life-saving, so important. Beautiful.
Thank you. Before we round this out, I want to make sure that we do get to what are the chances of having an FDA-approved treatment indicated specifically for NASH before the next International NASH Day. What do we think?
Well, just briefly answering that, but the only good news I want to give you is that ACE, which is the American Association for Clinical Endocrinology, is working on guidelines together with the Liver Society, the AASLD, and educating, and hopefully ADA is also in that direction. New treatments, there are many. I'm going to defer to Steve. Without getting down to the specifics, it's very likely that in the next, depends on some approvals by the FDA, but the next 1, 2, or definitely 3 years, we'll have more than one option. How do you see this, Steve?
Yeah, just again, bottom line up front, I don't think you're going to see anything in the next 12 months, Donna, specifically for diabetics and NASH. But there are a plethora of drugs coming. There's a huge groundswell. We tend to talk about that every year, but I can tell you from really about the time the pandemic hit on, we've had so many good news stories come out of early phase clinical trials and even mid-stage trials. And a lot of these drugs are modulating glycemic control in addition to defatting the liver and having positive impacts on NASH and fibrosis. So the story is a good news story. It's not over, and we don't have our first therapy that's FDA approved yet. But I can tell you that the FDA is keen to help develop a drug for NASH. The goalposts have not moved. You've heard that term before. I think they're locked in. If you want to hear more, I would just do a shameless plug for our single topic conference coming up June 17th and 18th, sponsored by FAASLD on NASH and drug development. And the FDA will be presenting at that conference. So stay tuned for that.
Fantastic. We'll include that in the notes on our website so people can link over to that and register to hear it. So what I've learned, and what I hope our audience learned, is diabetes has doubled, if not during the pandemic. People with type 2 diabetes probably have at least a 2/3 chance of having some form of fatty liver disease and NASH. And so their doctors should be screening them, or patients can use their own lab results and knowledge of their concurrent conditions and history to get their scores and bring them in to start a conversation with their doctors, whether it's primary care or endocrinologists. And then for those at highest risk, get a referral to a hepatologist to add that member to the team, and really put together a multidisciplinary team, either virtually or in one location, to make sure that we are controlling the controllable. All of the different metabolic risk factors of overweight, of hypertension, of high cholesterol, and diabetes and your liver diseases together can hopefully keep people from the throes of developing cirrhosis and cancer or needing a transplant. But it seems like we're gonna all need to wrap our arms around this to really have full effect. Did I hear that correctly? Did I get that right?
You did it right. So
yes, perfect.
any patient, we're all patients, right? So any listener should just ask their doctor, am I at risk? Can I be checked? And start the conversation. Maybe that's the best take home that we can make.
Proactive. Be proactive as a patient. That's
yeah. And I know you already have your tagline for this year's International NASH Day, but you summed it up brilliantly, and just saying we all need to leave a big fat dent on this planet in the name of NASH. We all want to take a broken piece and make a masterpiece, and it starts with disease awareness and identifying the at-risk patients, and that's at the patient level and at the primary care and gastroenterologist and endocrine level. So all of us have a role to play in leaving that big dent. So thanks for letting me be a part of that.
Thank you so much. Thank each of you. Thank you, Dr. Cusi, Dr. Harrison, Dr. Topsever. Thank you to everybody who's listened. Please join us for our other International NASH Day panels and videos from the World Health Organization, and our culinary event this evening as well. If you want more information on how to eat healthy, with NASH, or prevent your risk from it, join us at our culinary event this evening. But you can find all of our information on the Global Liver social media sites. Thank you. Stay well, stay connected.